that's it. We are ready to get started on best practices for effective medical care. So I'm going to turn you over to Tracy Sosa and Martu to begin. All right, here you go.
Great. Thank you so much, Davin. I am Tracy Sosa. I am one of the supervisors in the Prevention and Quality Improvement Unit here at the Justice Center.
And I am Martu Jabata. I'm a quality of care review specialist here in the Prevention and Quality Improvement Unit.
Hello, everyone. My name is Christina Newberger, and I am also a quality of care facility review specialist in the Prevention and Quality Improvement Unit here at the Justice Center. I will be mostly behind the scenes today, but I do just want to thank everyone for joining us today.
Thanks, Christina. And I just want to echo, thank you all so much for joining us today. With that said, let's go ahead and dive in and get started on today's presentation. So the agenda for today, we're going to talk to you a little bit about the Justice Center's abuse prevention resources. I think most people probably still think of investigations when they think of the Justice Center, but there's actually an entire department here at the Justice Center focused on the prevention of abuse and neglect. And one of our roles is to create prevention resources to share with provider agencies. So while we have you with us today, we're going to spend a few minutes to show you some of those abuse prevention resources, and then we'll shift gears to focus specifically on talking about our Spotlight and Prevention Toolkit for best practices for effective medical care. So next I'm going to turn it over to Martu, and she's going to walk you through those prevention resources, where to find them, and then how to stay up to date as we share new resources.
Thank you, Tracy. There are a lot of ways that you can learn about our abuse prevention product. Our website is rich with information and resources. We recently updated this website to make it more user-friendly and interactive. Everything that we will be covering during this presentation can be found on our website. Also, there is a QR code here on the screen, and you can scan that. It will take you directly to the abuse prevention page where you can view all of our abuse prevention products. So we're going to start off with a poll question. So the first poll question is going to come up. And we want to know, have you already subscribed to receive updates from the Justice Center? Oh, wow. Okay. We see that most of you have subscribed for update. Thank you very much. About 38% of you have not subscribed yet. So let's talk about it. When you access our website, you will be prompted to sign up for updates from the Justice Center. And these updates include Justice Center news and events. You get updates on training. You also get update on abuse prevention product, and you get update on resources for family and individuals. So if you ask me, I think that's a pretty good reason to subscribe for update. We are also on LinkedIn, and we regularly share information, including information about our abuse prevention product. So I encourage you to follow us on LinkedIn. So our latest and newest feature is our prevention blog, which is dedicated to sharing prevention resources. We usually share any updates about our prevention products on this blog. We also share helpful hints, some resources and tools from our prevention toolkits. Some of the spotlight may be too large. So the blog enables us to share bit-sized information and also update the field about our prevention product. All right. So the Prevention and Quality Improvement Unit here at the Justice Center is a small but mighty unit. And over the years, we have published a total of 11 prevention toolkits. The information offered in these toolkits include guidance and resources for agency and staff to use. It is intended to be a guide, and it can be modified to meet your agency's specific needs. We work hard to ensure that the information in these toolkits are applicable to all different licensing agencies. However, you may find that some of the toolkit may be more applicable to some programs than others. In addition to guidance for agency and staff, we also provide tools for agency to use. For example, our spotlight on best practices for choking prevention also have a sample mealtime observation form and a sample dining guideline plan. And that's something that is ready to use that agency can just print and use, or you can modify it to meet your agency's specific need. There are a lot more resources and tools in these spotlight, but we may not have the time to cover them. So I encourage you to go to our website and take a look at each of these toolkits. For today's presentation, we will be focused on the spotlight for best practices for effective medical care. And to start us off, I want to turn it over to the woman who has played a lead role in developing that toolkit, and that is Tracy Sosa. Back to you, Tracy.
Thank you so much, Martu. So before we really start talking about the spotlight, we do want to take just a moment to find out who's joining us today. So we have another quick poll question. So if you can take a quick moment and let us know which of the oversight agencies you work with, whether it's the Office for People with Developmental Disabilities, the Office for Mental Health, the Office of Addiction Services and Supports, the Office of Children and Family Services, the Department of Health, or the State Education Department, or maybe you're not affiliated with one of those agencies, maybe you're a family member, a self-advocate, you could choose other for that. But if you could just take a moment and let us know who you're with. And it looks like 63% of you are with OPWDD, so thank you for joining us. We have smaller numbers with us today from OMH and OASIS. Looks like we have just about every licensing agency represented here today. So thank you all so much for joining us today. As Martu mentioned, we do work really hard to ensure that our spotlights are applicable to all of the state oversight agencies and to all agencies under the Justice Center's jurisdiction. So it's helpful for us to know today, and as Martu said, you may find some information more applicable than others. All right, so if we talk a little bit about how this spotlight came to be, first and foremost, we did see a concerning trend in the number of cases being reported to the Justice Center that were related to medical care. When we started looking at all of those issues and concerns, we realized that they fell into two categories. And the first was case trends that was related to responding to medical emergencies. We saw cases involving people who froze when they were encountering somebody who was unresponsive and didn't know what to do, or saw that they were calling a manager or a supervisor instead of 911 for emergencies. So first, we created a spotlight for responding to medical emergencies, and that spotlight and its resources are easily available on the website, as Martu just showed you, and we encourage you to take a look at it. We also did a presentation at last year's summit on responding to medical emergencies, and that recording is available on our website for anybody who hasn't seen it and is interested in it. The second bucket of concerns and case trends that we saw was related to basic medical care, excuse me, and concerns related to people's medical needs not being met. So these concerns range from things like failing to bring people to their appointments or reschedule canceled appointments, either not recognizing when somebody was experiencing a medical issue or non-contacting a nurse or a manager when somebody was displaying signs or symptoms of illness, not giving medications as ordered. We also saw trends related to documentation, like failing to document medical concerns, vital signs, weights, medication administration, or other critical information. So the other area that we saw, so in addition to the case trends, which in and of themselves are concerning, they're also exacerbated by the unique needs of people receiving services in the settings under the Justice Center's jurisdiction. We know that studies show that people with disabilities are at a greater risk for developing other health disorders. which makes timely access to appropriate healthcare even more critical. So if we think about how many people that we support who, in addition to having maybe a developmental disability, also have a seizure disorder or a mental health disorder, or we know that people with Down syndrome are now far more likely to have an increased likelihood of having dementia. Again, so it makes timely access to medical care really important. In many settings, we're also tasked with serving an aging population, which also impacts and may increase the medical needs of people receiving services. And then we also know that many individuals rely on staff members to identify and report symptoms of concern, maybe due to limited verbal abilities. Maybe they need assistance reaching out to nursing or emergency services or scheduling medical appointments, or even to get them to healthcare appointments. Then we also have this delegation of medical responsibilities. So in many of the settings under Justice Center, the Justice Center's jurisdiction, it's direct support staff who have responsibilities for things like administering medications, monitoring vital signs, or scheduling medical appointments. They have a lot of responsibility for people's medical care, though most of the people or most of the staff in the field may not have a medical background. So that's how this toolkit came to be. The toolkit provides guidance and best practices to help both agencies and staff perform the critical duties to ensure people's medical needs are met. So when we look specifically in this toolkit, we're going to talk about many of these things in further detail on later slides. But just as a reminder, though, we're only going to be reviewing excerpts and highlights from the Spotlight. This entire Spotlight is available for viewing on the Justice Center's website. For our Spotlights, we want to provide both information and tangible resources that can be used by providers. And as Martu said, we hope that agencies will use the toolkits as a resource for training staff and to ensure that staff have all of the information, resources, and supports they need to provide effective medical care and to decrease incidents related to ineffective medical care. We believe everybody has a role in prevention. So for the creation of this Spotlight, we worked with different business units at the Justice Center to identify best practices in medical care and the things that both staff and agencies can do to help identify medical concerns early on and ensure that people get the medical care that they need. As we previously mentioned, we try really hard to make sure that our Spotlights are applicable to all settings under the Justice Center's jurisdiction, but you may find that some information is more applicable than others based on the population that you serve. And in this Spotlight, that's also where the concept of special topics come in. So in this Spotlight, for example, we know that though many settings are fortunate to have a nurse either available on site or available by telephone, we know that's not the case in every setting. So for this Spotlight, we have an entire special topic that provides guidance for settings that don't have nursing supports. Again, we'll mention that our Spotlight toolkits are more than just guidance for providers. As Martu mentioned, we created actual tools that agencies can use to support staff and people receiving services. In this toolkit, we have a sample pain chart that agencies can use to identify individual baseline concerns for people receiving services and warning signs that they may be experiencing pain due to medical concerns. And then lastly, all of our Spotlights contain, could this happen in your program scenarios that programs can use as a training resource for staff? And we're going to share some of those at the end of this presentation. So let's start looking at the Spotlight. So when we started looking at everything that goes into ensuring that people receiving services receive the medical care that they require, we found that there were a lot of components. So we created the acronym CARES to help providers remember some of the most critical elements for providing effective medical care to people receiving services. And CARES is referring to care plans, agency policies and administrative oversight, resources, education, and staff. So if we jump in and start looking at the first letter, C, that stands for care plans, here we're talking about care plans that identify medical concerns, treatments, and the supports that people require. So in order to provide support, staff first need to know what people's needs are. We know that some settings have more documentation requirements than others, but if a person receiving services has a medical condition or issue, it should be documented in a care plan so staff are aware of it. The care plan is a really critical tool for staff to be aware of people's medical needs and concerns and to ensure that everyone has the same information about a person's medical needs. So the Spotlight contains guidance for agencies to create care plans that address all medical issues and concerns. So if a person has a medical diagnosis and they require a medication or a treatment for it, it should be documented in a care plan. The plan should also address any adaptive equipment that people require. So if someone is taking a medication for a seizure disorder, we want to see that outlined in the plan. If they require adaptive equipment, like a mechanical lift to move them from their bed to a chair or vice versa, we would also expect to see that outlined in the plans. The plans should use plain, everyday language. So remember, the staff who are reading the plans need to be able to understand what the concerns are and what the expectations are for supporting staff, for supporting the person. So we need to be careful that the plans don't use too much medical jargon or terminology that somebody who doesn't have a medical background may have difficulty understanding. So for example, if somebody has hypertension, we would hope that the plan spells out and explains that hypertension is really referring to high blood pressure. We want plans to identify the baseline conditions for people receiving services. So under normal conditions, what does that person look like? So if we go back to our hypertension scenario, what is that person's typical blood pressure? Another example would be for somebody who may have limited verbal abilities, like what is their typical behavior? Would it look different if they were in pain? We would want plans to identify this information to help staff recognize when somebody may be experiencing a medical issue or a concern. We also want the plans to provide clear guidance for when to seek medical attention. So once staff begin to recognize that somebody may be experiencing a medical or issue or concern, they need to know at what point they should reach out to somebody for assistance. So if we go back again to the hypertension, high blood pressure scenario, the plans should identify at what point staff should elevate the concern about someone's blood pressure to a nurse or a manager or someone else. The care plan should really specifically identify the person's baseline, but also when staff should seek medical attention. So for the hypertension, high blood pressure example, so if the systolic number, the top number is above a certain number, or the diastolic number is above a certain number, that plan should then direct staff to seek medical attention. And the plan also needs to clearly and specifically identify who the staff should contact. Is it a nurse? Is it a manager? Are staff expected to take someone to the primary care physician? We hope that would all be spelled out in the plan. So plans also need to be reviewed on a regular basis, usually at least annually, and updated as needs change to ensure that they're accurate. So for example, if we have somebody who it goes from eating solid foods to having a G-tube, so they're no longer eating or drinking by mouth, we would need the plan to be updated to reflect that. Or if somebody receives new adaptive equipment, the plan should be updated. We know that some agencies have electronic platforms that they use to generate the care plans, but if making handwritten changes to the plan, we need to ensure those changes are legible, that they're dated, and they're signed by the person who made the change. When plans are reviewed and there's no changes, we want agencies to make sure there's some kind of mechanism to record that the plan was reviewed and that it was noted there was no changes. So we frequently see care plans that have some initials on them, but then it's not clear what those initials mean or even whose initials they are. So if a plan is reviewed and there's no changes, we recommend clearly noting on the plan that it was reviewed by Martu Jabata on this date, that there was no changes, and then Martu signs and dates the plan. That way it's very, very clear. We also need to make sure that staff are trained on the medical care plans on a regular basis and whenever there are any changes. Again, the point of the plan is for staff to have the information that they need to support people receiving services and ensure their medical needs are met. When possible, we recommend providing in-person training to ensure staff understand the plan content and their responsibilities for providing medical care. You'll hear us mention that a few times today. We know that there's a staffing crisis. We completely understand that it's not always possible to provide in-person training, but it really is the best way to ensure that staff truly understand a person's medical needs and the supports they require. Agencies also need to have a mechanism to ensure that all staff are trained. So this is including relief staff or per diem staff, staff who work in other houses and float over to cover shifts. And to have a mechanism in place to identify any staff who are absent from a training so that they can be followed up with and trained at the earliest possible opportunity. Of course, we always recommend documenting everything. Document. So document the training provided. We've seen some great examples from providers who document their training, like having the staff sign-in sheets that are pre-printed with staff names, and staff sign beside their name to indicate that they've attended the training. And that way it's very easy to identify somebody who wasn't at the training. Of course, technology is a wonderful thing now. We know that agencies can offer training over Zoom or WebEx. And we've also seen some agencies create some really great sign-in sheets that record whether staff attended in person, whether they attended virtually, or whether they ended up reviewing like meeting minutes or something after a meeting.
Tracy, I have one question from the chat. Somebody just wants to know, are care plans the same as PONS or, plans of nursing services?
Yeah, and that's a great question. Here we're using a very generic term for care plans because PONS is a term that's specific to OPWDD, but yes, generally that is what we're referring to. Okay, so moving on to the letter A. And in our CARES model, A actually refers to two different things. And the first A is referring to agency policies. We feel this is a really important foundation for providing good medical care. And we want to see policies that address routine medical care, as well as medical emergencies and situations that would require staff to elevate concerns to 911, an RN, or a primary care physician. So policy should identify who staff are going to contact if there's a medical concern. Is it the nurse? Is it a manager? Or are they taking the person directly to a doctor or the urgent care? We also need to know the method of communication staff should use to report medical concerns. So is it a phone call? Is it an email? Is it a text? Are we writing a communication log? It really needs to be spelled out. Agencies should also identify if there's somebody different to contact during typical business hours versus after hours. We've seen where there have been delays in care because staff contacted like a primary nurse or manager for a residence after hours when that person wasn't checking their phone or email, instead of the staff contacting like an after-hour service. Policy should identify staff responsibilities for providing medical care. So specifically, who does what? So for example, who's responsible for scheduling medical appointments for people receiving services if they need help with that? Who's responsible for completing medication inventories or reordering medications? Having those roles and responsibilities spelled out in policy really helps to avoid any confusion. We also need to know who's responsible for communicating health concerns across programs and across shifts. So for example, policies, should address communicating medical changes between different settings, like residential settings and day hab programs, schools and residential settings, and between behavioral health and inpatient units and hospitals. Everybody needs to be on the same page and have consistent information about the medical supports people require. Also, we need to know, what does communication look like between outgoing and incoming staff or nurses at shift changes? We've seen some agencies will use a communication log. Some agencies may have really quick change of shift meetings. So if I'm coming on shift at 3 o'clock and somebody that I'm supporting went to the doctor that morning and they need to have their vital signs monitored, or there's a medication change, how am I going to know that, right? So the communication really needs to be critical, and it's really helpful if it's outlined in policy or procedure. Lastly, we want staff training requirements to be identified in policy, especially for things like CPR, first aid, and Narcan administration. So for those who aren't familiar, Narcan is a life-saving medication that can reverse an overdose from opioids. We strongly encourage agencies to train staff on these topics so that they can provide a timely response in the event of a medical emergency. And we want those training requirements to be identified in agency policies. Okay, so the second A in our CARES model refers to administrative oversight. And here what we're really referring to is having a process in place to audit medical documentation and processes and to provide administrative oversight to ensure that people's healthcare needs are being met. So we recommend that agencies audit and review nursing care plans to ensure that they accurately reflect all medical concerns and supports as required by people receiving services. As we mentioned earlier, plans should be reviewed on a regular basis, usually at least annually, to ensure that they're up to date and accurate, and also that they're updated as people's needs change. So plans also need to be audited to ensure that they're consistent with one another. So one of the things that we frequently see is that there's inconsistent information in plans. So for example, someone's nursing plan might note that the person has allergies, but when we look at the medication administration record, it notes that the person doesn't have any allergies. We've seen some best practices from agencies implementing like a due diligence form that documents their checks of plans to ensure that they're consistent, and also documents any follow-up steps they're taking when they identify that there's inconsistencies. And we think that's a great tool. We also need to audit medical records to ensure that appointments are scheduled and attended as required. Of course, we know life happens, sometimes appointments are missed or they're canceled and they need to be rescheduled, but agencies should have. And again, we've seen some great tools from different agencies that they've created to track routine and specialty appointments to ensure that they were scheduled, completed, or rescheduled as needed. Medication records also should be audited on a routine basis to ensure that medications are administered as required. Unfortunately, blanks on the medication records or MARs are something that we see quite often. And medication administration is so important. So to the extent possible, we recommend not giving other responsibilities to staff who are assigned to administer medication, like not having them supervise people receiving services, ensuring that there's a quiet place where they're able to focus while administering medication, so that we can avoid medication errors or blanks on the MARs. We've also seen some agencies create a good best practice of having a second staff review the medication administration records after the med passes to ensure that there's no blanks on the forms. Another area where we see a lot of blanks or missing information is in other medical documentation, like the documentation of weights, vital signs, or on body check forms. Those forms will typically have a place for a manager or a supervisor or a nurse to sign them to indicate that they're reviewed. But when we look at those documents, we frequently see that there's missing information or missing signatures. This is important documentation that can indicate when somebody is starting to decline. So it's really important that staff are documenting this information. And performing those ad hoc reviews or audits of the documentation can help identify when or why it's not being completed, so that corrective actions can be implemented. And of course, we want you to document all those medical reviews. I think everybody's familiar with the saying, if it wasn't documented, it didn't happen. So document, document, document. So now we're up to the R in the CARES model, and this stands for resources. So again, many of the staff who are tasked with providing some of the critical medical supports may not have a medical education or background. So it's really important that they have the resources they need to be able to meet people's medical needs. So some things to consider is displaying signs or posters in program areas with guidance for staff. So for example, we've been on site and seen posters or signs with things like, if they fall, make the call, to help staff remember not to move people receiving services after a fall and to notify a nurse or a manager. We understand that in some settings, posters aren't ideal when trying to maintain a home-like environment, but you can always post things in a staff office. We've also seen a lot of settings who support people who are at risk for choking, where they have posters like on the inside of kitchen cabinets with reminders about, how to intervene if somebody begins to choke. So that's also a great option. We hope agencies are sharing resources such as health and safety alerts with staff. We know that many of the licensing agencies will frequently create and share health and safety updates that identify best practices for supporting people. So we hope those are being shared with staff. And of course, as Martu showed you, the Justice Center has lots of abuse prevention resources as well. So we hope that those are also shared with staff. Another resource for staff is sharing lessons learned from medical issues or concerns in program areas. This can be to share things that happened in one program where something went well, so that other staff and other programs are aware of what went well. So if they find themselves in a similar situation, they'll know what to do. Or on the flip side, you can share where something went wrong. So again, other programs are aware of what happened and they don't make the same mistake. So we've seen some agencies do really great things like creating lifesaver awards to recognize staff who intervened when someone was choking. And then they share that award and photos in their agency newsletter or on social media pages or on their website. And we think that's a great practice. Lastly, we want to ensure that direct support staff have a resource called a ready to go packet. So that's something that would typically identify a person's medications, any allergies, their primary physician, and contact information for families or guardians if they have one, in the event that somebody needs to go to urgent care, the doctor, or emergency room with short or no notice. We know that in this climate with staffing challenges, it very well could be a float or a relief staff or somebody who's not familiar with the person who's accompanying the person to the doctor's appointment, and they may not know the person. So that ready to go packet can be really helpful for that staff who may not know that person, to ensure that all that critical important information is shared with medical personnel. So next, we're going to share a snippet from a pain chart. This is one of the resources in this spotlight. Oops, sorry, is there a question?
I'm sorry, there's been a couple questions that came in. So one of them, someone wanted to get some suggestions for including medical needs in care plans when care plans are really intended to be person-based on a person's goals, and the person's goals may not include medical needs. So do you have any suggestions or tips for including that?
So I think in most settings where we think about people's medical needs and plans, we're thinking of a separate plan for medical needs. So to the extent possible, having separate plans. But if a person, has goal plans, maybe they're a self-advocate, or maybe they're more independent in their health needs, maybe a goal can be created to help them in terms of accessing medical care or making appointments or things like that.
And do you have any recommendations if a provider agency is doing a home visit in relation to documentation in MARS? And I'm sorry, I don't have any more information about that question.
Can you repeat the question? Sorry.
If somebody how do you document MARS if you're doing a home visit for a person? What has happened?
So if the person has a MAR, I guess it depends on who's administering the medication, right? Some people are able to self-administer the medication and initial law for it. If it's a home visit where the intent is to help facilitate the administration of medication, I would still hope that there's some sort of form there, that can be initialed or signed off on to reflect the administration of medications. I hope that helps to answer that question.
I think it does, Tracy. Thank you. Another one, someone just mentioned that, I think some agencies, largely OPWGD, are sometimes told to make it a home-like environment and not, have too many posters. Do you have any suggestions about balancing that?
Yep. So like we mentioned, those posters maybe can be posted in a staff office, where it's not necessarily going to impact the home-like environment, but staff are still able to see the guidance. We've seen agencies put posters on the inside of kitchen cabinets, like with choking interventions. We've also seen guidance in frames. So it's not necessarily jumping out at you that it's something other than what you would see typically hanging on a wall. You can also have information in binders. That's something that we frequently see when we're on sites, so that it still kind of comports to that home-like environment aspect.
Just so you know, you got a beautiful suggestion. Thank you for your response to that. And then it's a question that I'm going to answer. Someone wanted to know, how often do we look at care plans in congregate settings, RTFs, RTCs, and how do we enforce compliance? So we don't look at every single care plan for everybody. That is really the state oversight, the licensing agency's responsibility to be monitoring compliance with regulations, and we don't force compliance at the Justice Center. We make recommendations to help improve the quality of care, and that is always the spirit in which our recommendations are offered. All right, there you go, Tracy.
Right, thanks, Davin. So this resource is a pain chart, and this is in the Spotlight on Prevention. I believe it can be found on page 12 of the Spotlight. And this pain chart we think is a fantastic resource for agencies to help staff recognize when somebody may be in pain, which could indicate an underlying medical issue. This chart is especially helpful for people who have limited verbal abilities and may have difficulty articulating when they're experiencing pain or discomfort. The chart can be created with the help of family, if there's family available, or with friends or staff who know the person well. And the concept is that the chart identifies how the person would look under normal circumstances, their baseline condition, as well as how they would look if they were starting to experience pain. So in this example, we have a couple of areas, for, what the person's skin would typically look like, what their expressions would look like, both when it's green, meaning the person is in their typical baseline situation, or where it's yellow or red, which may indicate that change in behavior could indicate that the person is starting to experience pain. They may require maybe some medical intervention or elevating that concern to, again, a nurse manager or administrator to help ensure that that person's medical needs are met. So when we get to the E in the CARES model, we're talking about education. And here we're really talking specifically about staff training and education. And that's education on care plans, policies, adaptive equipment, and all medical supports that people require. So we want to see staff trained on things like signs and symptoms of illness. So again, for staff to be able to recognize that somebody is ill in order to receive medical attention, they need to know that that person is displaying a sign or a symptom of illness. It's also important that staff are aware of when somebody deviates from their baseline. So in addition to general training on the signs and symptoms of illness, we encourage agencies to provide person-specific training, especially if you're using something like the pain chart that we just demonstrated or something similar. So staff are aware of the unique signs and symptoms of illness that a person may have. We want staff to be trained to report specific symptoms when they're contacting a nurse, a manager, or an administrator. So for example, instead of calling and elevating a concern that somebody seems off or that their blood pressure is high, train staff to report the person's specific vital signs. So like, for example, that their blood pressure is 180/90, that they have a fever of 102. They vomited 4 times in the last 90 minutes. The more specific, the better, so that whoever's receiving that call, whether it's a nurse, a manager, or administrator, can really provide informed guidance to staff so that, again, that person's medical needs can be appropriately met. I know we've touched on this before, but it bears repeating to ensure that staff know how to communicate with that nurse or manager who's receiving the information. Are they texting them? Are they emailing them? Is it a phone call? Similarly, make sure staff know to ensure that they receive some sort of confirmation response from the nurse or manager whenever they reach out to ensure that the nurse manager, whoever has received that information. We've had cases involving delays in care because staff sent an email or a text to a nurse or a manager and assumed that the nurse or manager had the information, only to find that it was that nurse or manager's day off and they weren't checking their emails, or because of connectivity issues, the information was never sent through. So there was a delay. So it's really important that staff ensure that they receive some sort of confirmation from whoever they're contacting to ensure that that information was received. We also want to ensure that staff are trained on the importance of documentation and why it's important to document, because again, we see so many blanks on medical forms. So staff training should address things like the importance of ensuring that MARs are initialed, medication administration records are initialed to reflect that medication was given, to document when PRN or as needed medication is given, then that things like weights and bowel tracking and body checks are all documented thoroughly and accurately. Hopefully when staff understands how much this documentation is relied upon to identify when there's a possible change in a person's medical status, the documentation will be more complete. Lastly, we also want to ensure that staff are trained on adaptive equipment. So things like how to use mechanical lifts and the importance of using 2 people at all time when using a lift, how to ensure they're using the correct sling for a lift. Same thing with dining equipment, if there's adaptive equipment with dining. And again, we've seen some really great things from agencies, like having pictures of slings on like the mechanical lifts or having slings labeled so staff know which ones to use. So again, when we talk about education, as much as possible, we recommend agencies to provide in-person training. Again, we totally recognize that there's a staffing crisis and that that's not always possible, but in-person training, again, really is the best way to ensure that people understand the training content for staff to be able to ask questions, for whoever's training to ensure that staff understand, what's happening. And we've seen some agencies who have great best practices, like agencies who require in-person training on nursing care plans that involve certain complex diagnoses. We've also seen some agencies be really creative and create little quizzes for staff to take to ensure that they understand all the information that's outlined in care plans. And again, here, technology can be a great resource. If staff aren't able to attend training in person, maybe there's an opportunity to offer that training with a virtual component for staff to be able to attend via Zoom or WebEx. However the agency chooses to provide the training, we need to ensure that there's a mechanism in place to ensure that all staff who are absent from a staff meeting or other situation where training is provided receive that information. So this is staff who work multiple jobs, per diem staff, part-time staff, staff who work the overnight and they can't stay on to attend a morning training. And again, we encourage agencies to use sign-in sheets that are pre-printed with staff names, so it's easy to identify missing signatures next to those names, so you can follow up with those staff and train them as soon as possible following the meeting. So again, they have all of the information that they need to support people receiving services and ensure those medical needs are met. And as previously mentioned, we also think it's so important for staff to be trained on CPR, first aid, and Narcan administration. And again, Narcan is a life-saving medication that can reverse an overdose from opioids, and an overdose can happen at any time, anywhere. So it's important that staff are aware of what this medication is and how to administer it. Lastly, we encourage agencies to provide some sort of sensitivity training to staff to support a thoughtful, person-centered approach to providing services to vulnerable people. So these are things like training for staff where they experience maybe what it's like to be lifted in a mechanical lift or transferred or be fed by somebody else. Being in that experience where you are vulnerable can really shape how staff choose to interact with people after that. We would like to see staff trained to really talk to people and explain each step of care being provided. So for the situation where somebody is using a mechanical lift, to really explain to the person, okay, we're about to put you in the lift now. Or if you're feeding the person, okay, are you ready for another spoonful? And really just helping staff understand the importance of being patient with people who have limited verbal abilities and may take longer to articulate any pain or discomfort they may be feeling, or who may display behavioral changes when they're in pain. And to encourage staff to allow time for people to speak when they need more time to explain themselves. These small things can really make a big difference in terms of the quality of care provided to people receiving services. Last on our CARES model is the S, which stands for staff. And before we jump into and start talking about this component, we have another poll question for you. The poll question that's about to pop up, and you'll see where we're going with this in just a minute, but we do like to know how many of you work in a setting where you're required to document periodic checks on people receiving services. So if you could give us a quick yes or no to let us know if you work in one of those settings. And then if you answered yes, that you do work in a setting where you're required to document periodic checks on people receiving services, can you let us know what you're checking for? Is it to visualize the person and indicate that you know where they are? Or is it to indicate that the person was visualized, but you're also confirming signs of life? Like you hear the person breathing, you're visually seeing the rise and fall of the person's chest. Or if you answered no in the first part, you can answer no in the second part. So if you could just take a quick second and let us know what you're doing with periodic checks. It looks like we've got some results coming up. So about 44% of you, so less than half, are being required to document. And of those 44%, it's pretty much evenly split. 25% of you are documenting that you know where the person is, and the other 27-ish% are documenting that you're confirming signs of life. All right, perfect. Thank you so much for sharing that information with us. You'll see where we're going with that in just a second. So the last letter in the CARES model for staff is really acknowledging that staff are an agency's greatest resource. So of course, our toolkit is going to contain guidance and suggestions intended for staff to follow. So we've identified best practices for staff to provide effective medical care, including following all agency policies and procedures for providing medical care and support. We really need to make sure that staff are trained on those agency policies, because of course they have to know what the policy says in order to be able to follow it. We often see great policies from agencies, but when we ask for staff training on the policies, we find that staff haven't been trained. So make sure staff are trained. We want staff to review care plans, including medical care and treatment plans, to ask questions if they have any, if something's confusing or if they need any clarification. Again, the point of having the plans is for staff to be able to reference them to understand what people's medical needs are. We want staff to ensure that they attend staff meetings where training on care plans and agency policies and procedures are provided. Again, we understand it's a challenging climate, but staff need to be aware of what they need to do in the event of a medical situation. If staff miss meetings where training is provided, they need to know what the expectations are following that. So are they required to review meeting minutes? Do they need to sit down with a manager or supervisor? They need to know how to get that important information. And then here, we're going to talk a little bit about where the poll came into play. We want staff to complete all required supervision and safety checks and know why they're completing them. So one of the things we see sometimes in cases is that it's not clear what staff are checking for. So they're completing a check, but it's not clear if they're just checking to indicate that the person is there and they're being visualized, or whether they're checking for signs of life. So if you work in an agency and it's not clear to you why you're documenting safety checks, we encourage you to go back and ask for clarification on what you should be checking for. We also want all documentation to be completed thoroughly, accurately, and legibly. Again, this documentation is going to be reviewed by nursing managers or administrators to help identify any trends, issues, or concerns. So they need to be able to read it. So that is the CARES model. Effective medical care, though, is such a broad topic that we have additional topics to cover that didn't fit quite as neatly into the CARES model. We're going to take a quick 5-minute break and we come back.
Before we do that, I'm going to ask you a couple questions that have come through in the chat.
I knew I couldn't get away.
No, it's just 2. It's fine. Somebody wanted to know if periodic checks are a requirement in regulations or guidelines. What advice would you give to that person? Find that out.
I think go back to the person's plans of care. Look to see what the plans of care say as far as checks, because it varies from person to person. Some people might need to remain, within, a visual, what's the word I'm looking for? I'm looking for Christina, line of sight, level of supervision. Other people might require 5-minute checks or 30-minute checks. So I would go back to the plans of care for that person to see what the individual requirements are.
Excellent. And the last question is, if a virtual training is used, is it a best practice to have the trainer available to answer questions from people who are attending the training?
If that's possible, absolutely. And again, the opportunity for staff to ask questions is so important, if there's clarification that's needed. But I always think about, too, the person who's too quiet or shy to ask a question. So if you're in an in-person training and staff raises their question or raises their hand to ask a question, chances are the answer to that is going to help somebody else who had the exact same question but was reluctant to raise their hand and ask.
Thank you, Tracy. That's it.
Thank you and welcome back from our short break. We are still on the topic of effective medical care, but we're going to shift gear a little bit here and talk about what we call special topic. But as Tracy mentioned, these topics do not fit into the CARES model, but they are essential when it comes to ensuring effective medical care for people receiving services. So for this portion of the presentation, we will be covering best practices for programs without nursing support. We'll be talking about health changes and declines. We'll also be talking about telemedicine, new admission, discharges, and then we're going to end the presentation with case scenario. Could this happen in your program? So we want to start you off with a poll question first. So do you work in a setting where there is nurse available, either in person or by phone? Oh, wow, yeah. So I can see most of you, 79% work in setting where you have nursing support. However, 21% of you work in setting where you do not have a nurse available, either on site or by phone. So, and that is, what we're going to talk about in this section, right? Program without nursing support. Because whether a program have nursing support, it is important to ensure that people receiving services receive effective medical care. So therefore, for program without nursing support, it's important to ensure that staff understand what constitutes a medical emergency. What are they supposed to do when a person is experiencing shortness of breath? What are they supposed to do when somebody falls and cannot get up on their own? Or when there is a head injury? Having a medical emergency protocol for staff to follow when responding to medical emergency can make a lot of difference. And that starts with staff training. Though it's not required for all programs, but it is best practice for staff to be trained on first aid, CPR, and Narcan administration, because it can make a difference, during a medical emergency. While staff are waiting for medical emergency personnel to arrive, they can be able to provide that life-saving measure. Also, by having those training, it helps staff to recognize what a medical emergencies are, signs and symptoms of illness, or behavior changes that could indicate an underlying medical issue. Also, we have seen incidents where life-saving care or treatment was delayed because a staff first contacted the nurse before calling 911 for a medical emergency. We want to highly encourage that agency empower their staff to call 911 first before calling the nurse or calling a supervisor. For program manager, supervisor, or administrators that provide after-hours support to staff, empower your staff to call 911 before calling the nurse or supervisor. Because we see when staff are empowered to call 911, they are more likely to make that call without hesitation. Also, if the provider play a role in addressing that person's medical needs, like scheduling a medical appointment or creating and updating medication administration record, you want to ensure that your agency policy clearly identify who's responsible for that role. You also want to ensure that the program staff or a designee attend medical appointment as needed to assist in making sure that that person's medical concern are discussed and addressed during those appointments. And also, we want to make sure those appointments are documented as well. So also you want to ensure that policy require the staff, I know Tracy asked about checks, also does your policy require staff to conduct checks, like visually confirm that person's well-being or do signs of life check? We also want to ensure that administrative oversight when it comes to medication, how medication are stored. Sometimes people are on controlled substances, make sure that they are properly secure and that they are disposed of as needed. And for some programs, you have some people receiving services who can self-administer their medication, and we want to ensure those medications are also properly secure and stored in the right places.
Hi, Martu. A couple questions came up about Narcan. So is a prescription required for getting Narcan? Some agencies don't have doctors, so they don't know how to get it.
You can get it at any pharmacy.
And yes, my understanding is you do not need a prescription for Narcan. You can get it at any pharmacy. It's over the counter.
And the next question is, if an agency doesn't administer medications, Should they still have Narcan available? What's your recommendation?
Yes, we highly recommend that even if you don't administer medication to have it, because it is a life-saving treatment.
Thank you.
All right, so we're gonna move over and talk a little bit about health changes and decline. We know that health changes and decline can occur at any time, especially with an aging population. So as these changes occur, we want to ensure that care plans are updated to reflect the changes. Also, it is important for staff to be trained on those changes, and also for staff to communicate any change in that person's behavior that could possibly indicate an underlying medical issue. Unfortunately, with health changes comes decline in other areas. So we want to ensure that when there's a health change or decline, we're also conducting assessment following that health change or decline. And that include like swallowing evaluations, mobility assessment, supervision, activity of living assessment. You know, maybe before health change, Martu was able to use the bathroom on her own. Martu could shower on her own, dress herself, and Martu was independent with staff present. After the health change, we want to assess whether Martu need a higher level of supervision. Can Martu still ambulate without assistance? Can Martu still shower herself? Can Martu use the bathroom independently? So it's good for us to do those assessments just to ensure that we are meeting all of the person needs. Also, following any significant dental work or other changes that may increase choking risk, we also want to ensure that swallowing evaluation are also done, and also that dietary consistency are changed, because sometimes you have situations where people have dental work and they may have been on a ground diet prior to that dental work. And after that dental work, we want to conduct an evaluation to make sure, can they still tolerate that ground diet, or maybe they may need a puree diet. Another way we can improve communication between staff and the clinical team is, by the clinical team attending a staff meeting. We've seen some programs where you have nurses and other clinical staff attend staff meeting, because that can foster a two-way conversation between the staff and the clinical team. Because sometimes, as much as we emphasize documentation and we highly encourage documentation, there are times that staff do not document everything. And sometimes during staff meeting, while having a conversation, you may find out that for the last week, Martu has been going to bed 7 p.m. when Martu usually the last one going to bed. And that may not mean anything. Maybe she's just tired that week, or maybe that could signal something else is going on, and staff need to monitor more and keep an eye on Martu. Also, following any procedure that requires sedation or anesthesia, people receiving services may not be at their baseline. So we want to ensure that care plans also reflect what that person's supervision level is going to be after that person is sedated. All right. Maybe I am independent with staff present in the house, but when I am sedated, I'm not. I require range of skin supervision. I require assistance when I'm going to the bathroom. So we want to ensure that the care plan clearly reflect what that person's supervision should look like following a sedation. We also want to ensure that agency policy clearly identify who is responsible for providing clinical support outside of regular business hours. And also, like Tracy had mentioned, how are staff supposed to contact that person? And not just the regular staff in the house, but also think about relief staff, because of the staffing crisis. Most of the time, people are floating from one house to another. So do you have that information posted somewhere that is easily accessible for a relief staff, somebody who never worked that house before to know that if it's on a weekend or it's a holiday or it's 8 p.m. at night, who do I contact? And that person name and contact number is there. Also, you want to have a system to document on call that made after hours and also ensure that those directives are being followed. All right, so let's talk a little bit here about telemedicine. You know, telemedicine has become more accessible over the years. We also know that telemedicine is convenient. With the staffing crisis impacting programs all across the state, trust me, we hear you, we know. Telemedicine is another way for program, you know, to schedule an appointment without having to worry about finding that extra staff or having two staff, because if you need somebody to drive and you need another person to provide supervision during transport, that means you need two staff to take that person to an in-person appointment. That is a daunting task. So with telemedicine, you know, that's one less thing program, you know, have to worry about. However, while telemedicine may be ideal in some situations, it is best practice to ensure that policy address telemedicine expectation, including acceptable scheduling practices, documentation for telemedicine appointment, and staff and clinical support during that telemedicine appointment. It's also important that we do not substitute hands-on appointment for telemedicine appointment or any specialty or consultation that require an in-person visit. So for example, if Martu falls, I know I'm picking on Martu a lot today, but if Martu falls and can't get up on her own, Martu needs to be seen by a doctor. We're not scheduling a telemedicine appointment for Martu. Also, that same thing goes if Martu, again, have a 105 fever, you know, we also want Martu to see a doctor in person. The next time I'll pick on Christina. And whenever possible, we want to include that person's support network. So that includes like the person's family, friend, or even staff who know that person. And include the person themselves when possible to make sure all of their needs are being met and they are addressed. So let's talk a little bit about new admissions. Okay. The one thing we can all agree on here is that we share a dedication when it comes to quality care for people receiving services. So ensuring that there are policy and procedures in place before the person is even admitted to the program. And while that person is in the program, those are keys for successful outcome. So before that person is even admitted to the program, we want to ensure that we are conducting a comprehensive clinical screening to ensure that all of that person's medical needs can be met. And that screening includes nurses, physical therapists, speech pathologists, and other clinical staff to make sure we are covering all bases. We also want to make sure that medication administration records are prepared ahead of time. If we need to order any medication and have it on site, that we have those medications on site, and that staff are also trained on that person's care plan before they are even admitted to the program. And as always, we encourage that you get information from that person's support network, including family, friends, and that person themselves to develop background information. Checklists are very important too. We hear that a lot of programs use checklists, and we highly recommend that because the thing is, I know I cannot depend on my own memory, but having a checklist, you can go through that checklist and make sure that you have all necessary documentation and that all the different assessments were completed and we have the information that we need. We also want to conduct assessment and develop care plans that reflect that person's mobility and dining guidelines, as well as risk assessment. So we want to ensure that our care plan reflects who is that person healthcare proxy? Medical order for life-sustaining treatment information. Do not resuscitate status. So most program, when a person is newly admitted to the program, within a certain time frame, they will conduct a fire drill to make sure that that person can safely evacuate in an event of emergency. And that is a really good practice. Also, you want to consider placing that new admission in rooms or in location that is near a staff office or nursing station to ease monitoring. Also consider ground floor for people who have mobility issue or people who are aging. And again, most programs have what they call grab to go binder, or if you have electronic records, you want to make sure those records are updated as well. All right. So we're going to move on and talk a little bit about discharges. So following a discharge from a healthcare facility or from a rehabilitation setting, there are always an aftercare plan. Usually it's follow up with your primary doctor. Sometimes it's like specialty appointment that has to be made or was already scheduled and has to be followed up on. So it is best practice to ensure that agency policy identifies staff responsibility following discharges, such as who is responsible to follow up with that appointment, who's responsible to order medication or adapted equipment if applicable. How will staff know where to take that person, when to take that person? So we want to make sure that is clearly identified. Also, with discharges, we want to be working closely with that healthcare facility for discharges. So it is important when somebody is admitted, whether it's in a hospital or rehabilitation setting, for us to closely work with that facility to plan discharge. Because when we are in contact with that facility, we will know whether the facility is planning to discharge that person on a Friday. Are they planning to discharge that person on the weekend? Or are they planning to discharge that person on the holiday? And in those cases, we can plan to have adequate staffing and supervisory oversight available when that happens. But more importantly, before that person is discharged, we want to make sure that we visit that person to assess their physical and mental status. We want to ensure that whatever changes that is occurring in the hospital, so maybe there were changes in that person's medication, maybe that person is struggling with ambulating, they need a walker or they need a wheelchair now. We want to make sure that we are assessing all of that. Maybe their dietary consistency have changed since they've been in the hospital. So we want to ensure that we are assessing that while that person is admitted, whether it's in the hospital or rehabilitation setting, so we can update those care plans, have staff trained on those health care plans before that person is even discharged from the healthcare facility. Also, like we talk about the admission process, in every step of the way, we want to be including that person's support network. Sometimes you have staff who have worked with people receiving services for years, and they can be an advocate for that person, and they can also, have a lot of information. So we want to be including the person when possible, but also their family members and also staff who have worked with that person during the discharge planning process. Okay, so like I mentioned, we're going to talk about case scenario. So our spotlight on prevention, they reflect case scenario, and these scenarios are based on incidents reported to the Justice Center. These are not actual cases. So the case scenario include a narrative of the incident, but they also highlight case concern. These case scenarios are a great learning tool, and I encourage you to use that during staff meeting or doing training to reinforce learning. Because we stress train your staff, but how do you know that your staff know what to do in case of an emergency? So these case scenario can actually test staff knowledge about what to do in case of an emergency. So we're going to take a look at a few of these case scenario. All right. So this is by Monique. Monique requires 15-minute checks to monitor signs of life. During the evening shift, Monique refused dinner and their gait appeared unsteady. The nurse was not notified. Staff noted that during Monique's 7:30 check, Monique's eyes were open, but when staff called their name, they did not respond. At 8:15 p.m., Monique was discovered unresponsive and 911 was called. CPR was initiated when emergency personnel arrived and Monique was transported to the hospital. So as we can see from this case scenario, there are a lot of concern, starting with Monique refusing dinner. If Monique is somebody who is anxiously waiting for dinner, finish all of their dinner, also asking for second, when Monique refused dinner, that's a sound something is going on. But also Monique gait is unsteady, so that tells us something is wrong. However, staff did not notify the nurse. And again, we see in terms of the checks that Monique was checked on and Monique was present. However, when staff called Monique's name, Monique did not respond. And then Monique is discovered unresponsive, but CPR was not initiated until emergency personnel arrived. And earlier on, we talked about the importance of training staff on first aid CPR and Narcan administration, even though it may not be required in our program, but these are life-saving treatments. So let's look at our second scenario. And this one is Paul. Paul is receiving treatment for substance use disorder and lives in a residence where alcohol and drugs are not permitted. Staff observed Paul slurring their words and walking with an unsteady gait. Staff documented suspected drug use and observed Paul take their medication before going to bed. The next morning, Paul was found unresponsive and transported to the hospital where it was discovered Paul suffered a stroke. So again, you see again with this case scenario, there were a lot of signs that were missed, with Paul slurring their words, unsteady gait, staff documenting suspected drug use when they didn't know what was going on with Paul. And now we found out that Paul had a stroke. So let's look at our last case scenario. And this is regarding Charles. Charles is blind, nonverbal, uses a wheelchair, and requires 2 staff for transfers. Relief staff Tom transferred Charles out of his bed by themselves using the lift. Tom pushed Charles down the hallway in the lift toward the bathroom. The lift got caught on a doorway threshold and Charles fell out of the lift and hit their head. Staff put Charles in their shower chair, completed a body check, and Charles did not appear to be injured. The next morning, Charles' right eye was bruised and swollen, and they were lethargic and began vomiting. So again, another concern here with Charles and the injury and staff not notifying the nurse because Charles didn't appear to be injured. So again, as you can see, these case scenarios, these are really great tools that can be used to test your staff learning and the training that you have been given them to see whether they know what to do in case of an emergency. So we just want to thank you for attending this presentation, and we hope it was helpful. So please do not forget to check out our website and the social media platform. Also, subscribe for updates if you haven't done so already. If you have any questions that weren't answered, please put in the chat box and we will do our best to answer them.
Thank you, Martu and Tracy. And this is the last question that we had in the chat box, which is how can we make suggestions about good prevention products or topics? And this is the email address that you can use to submit your suggestions. We welcome them. We can't do this work without you. Thank you, Tracy and Martu. Great job.